background information along with an online educational escape room activity to help us apply information from the AGS 2019 Beers criteria to patient cases. So we're excited about this activity. My name is Rebecca Brynjolfsson, and I'm a faculty member at North Dakota State University in the School of Pharmacy. I have certification in ambulatory care pharmacy and also in geriatric pharmacy. And so that's my area of expertise. And I also work with our practice experiences for students. We are excited to be able to partner with UND to provide some pharmacy-based education for these ECHO sessions as well. So our objectives for today are to identify the primary purposes of the AGS Beers criteria, to identify key principles guiding the use of the Beers criteria, and to apply the Beers criteria to patient cases in an educational escape room activity with your peers. When it comes time for the escape room activity, Julie will be helping us out and will actually be breaking off into Zoom group teams. So you'll be with a series of colleagues, and you'll be able to access the link to the escape room in the chat. And so when we get there, we'll explain that a little bit more, but just so you have an idea for that as well. And we hope that you will, again, turn on your cameras when you're working with your peers to complete the escape room activity. So the first thing I wanted to do was start off by giving just some background information on the American Geriatric Society, or AGS, 2019 updated Beers criteria for potentially inappropriate medication use in older adults. You have probably heard about the Beers criteria before. You've maybe heard that term. This is a practice recommendation that is updated on a routine basis by the American Geriatric Society. And it takes into account feedback from lots of stakeholders to really help us to be able to identify some key interventions for medication use for older adults. So the American Geriatric Society publishes these guidelines. The patient population these guidelines apply to are adults over the age of 65 years, and they really are meant to relate to all practice settings with the exception of hospice and palliative care. There is a lot of medication information that is included in these guidelines. So there are 5 primary tables that contain information, and I'm just going to quickly go through the tables so that you have an idea of what types of information you might find in these guidelines. So there's one table that talks about potentially inappropriate medication use in adults, and this table has a lot of medications listed along with rationale, strength of evidence, and then quality of evidence, and then strength of recommendation, I should say. So really it is a systematic or logical approach to looking at these medications. The second table that you'll find in this guideline would be potentially inappropriate medication use in older adults due to drug disease or drug syndrome interactions that may either exacerbate the disease or syndrome. So for example, you would find information on medications that shouldn't be used in older adults with heart failure, for example. There also is a list of potentially inappropriate medications, drugs that should be used with caution that you'll find. You'll also find potentially clinically important drug-drug interactions that should be avoided in older adults. And we'll talk a little more specifically about those, or you'll learn a little more specifically about those during our escape room activity. And then the last portion is medications that should be avoided or have their dose reduced with varying levels of kidney function in older adults. So again, not necessarily that a medication should be entirely avoided, but at what point do you recommend decreasing a dose or avoiding the medication altogether based off of kidney function? In order to help us get a better understanding of the guidelines, we're actually going to use the teaching slides from the American Geriatric Society. And these are the teaching slides that are available for patients, clinicians, health systems, payers as an educational tool to help providers understand, as one group, how to use the Beers criteria. So the first thing that the American Geriatric Society touches on is the purpose of the Beers criteria. And I think this is really good to recognize the purpose is really to improve patient care. So to identify potentially inappropriate medications. as the information will show, we're identifying potentially inappropriate, not definitely inappropriate medications. There are some medications that may be appropriate to use in certain patient situations or patient populations. Clinical judgment is always important and critical, but these are helpful to help us identify things that we need to look at a little more closely. It also can help us to reduce adverse drug events and drug-related problems, to improve medication selection and overall medication use in older adults. This tool is one tool that can be used to help improve medication use. There are a lot of other tools that we've talked about in previous echoes, and that I'm sure we will continue to talk about in future echoes to help us improve medication management for our older adult patients. And really, again, as we talked about, these are designed to be used in any clinical setting, also used as an educational, quality, and research tool. So for example, in our pharmacy curriculum, we would talk about the Beers criteria with our students so that they had an understanding of which medications are on the Beers criteria, which medications would be potentially inappropriate. So as they're scanning medication lists for appropriateness, those would stick out to them. So these criteria were created as part of a work group, and the work group ended up developing 7 key principles. And these key principles help to guide how we use these criteria in our practices. So we're going to go through the 7 key principles that the work group identified. Again, the most important take-home message they have is use clinical common sense. So they're intended to support and not contradict common sense and good clinical care. So their first key principle is one that I touched on a little bit already. Medications in the 2019 AGS Beers criteria are potentially inappropriate, not definitely inappropriate. So this work group looked at benefit versus harm for older adults in general. And they looked at that in light of other alternatives to determine whether medication should be on the list or not. And they do recognize that there are some older adults in which these medications may be appropriate. So even though it's appearing on this list, it doesn't mean that it's absolutely inappropriate for every older adult patient. So the meds in the criteria merit special scrutiny, but they should not be considered definitively inappropriate. The other key principle they have is to read the rationale and recommendation statements for each criterion. They do have caveats and guidance that are listed with each of the recommendations. Again, the whole idea of medication appropriateness is not black or white. We often teach in our program that guidelines are a starting point, not always the ending point, right? So we start with what the guidelines say and we think about how those apply to our patients. Many medications are considered only potentially inappropriate in specific circumstances. We'll have some examples of those today in our escape room. And understanding the meaning and purpose of the criterion is really important for being able to interpret them properly. So understanding why medications are included in the AGS Beers criteria and adjusting our approach to those medications is important for our third key principle. So again, the rationale statements for why it's included is important to look at. The reason a medication is in a criteria can help guide how stringent we should be in avoiding it. And again, it also allows us to individualize decision-making. Key principle number 4, optimal application of the 2019 AGS Beers criteria involves offering safer non-pharmacologic and pharmacologic therapies. So the AGS has been working on developing a list of alternative therapies, but they also want to point out to us that many alternatives are non-pharmacologic strategies and can include things like counseling or lifestyle changes. So it's always important to think about if a patient actually needs a medication. And I know that's hard when pharmacy, medications are the thing that we know the most about, but sometimes knowing the most about things can also make you the more cautious about them than any other group. And so recognizing that sometimes medications aren't always the be all end all for a patient, that there are other options and that we should still think about those. Key principle number 5 is the 2019 AGS Beers criteria should be a starting point for a comprehensive identification and improvement of medication appropriateness and selectiveness or in safety. So this is really only captures a small percentage of medication-related problems. There are a lot of other potential medication-related problems that we, again, have talked about in either previous ECHO sessions, or we'll talk about in future ECHO sessions when we talk about deprescribing, for example. But these are a starting point for reviewing a patient's medication regimen. We still have to think about other reasons why medication may or may not be appropriate. So is it indicated in the patient's disease states? Is the patient able and willing to take the medication? Can they be adherent to the medication? Are they having any adverse effects from the medication? Is the patient missing medications that they should be taking? Are they taking medications that are no longer indicated? Those are all questions that we ask as we think about medication appropriateness and safety. Since these guidelines can also be used by payers, one of the other key principles that the work group identified was focusing more in with payers and recognizing that access to medications included in the 2019 AGS Beers criteria should not be exclusively restricted by prior authorization and or health plan coverage policies. So again, thinking about the rationale behind why a medication is included on the Beers criteria list, it may be inappropriate for some patient populations, but not all patient populations that are older adults. So key principle number 7 is our final one, and this is the 2019 AGS Beers criteria are not equally applicable to all countries. So these were developed primarily based on medications available in the US. And so that doesn't impact us as much, but it is one of the key principles of the work group. So the application of key principles for patients and caregivers, clinicians, health systems, and payers. So they would like us to think of the AGS Beers criteria as a warning light. So whenever you think about prescribing or renewing an AGS Beers criteria medication, the warning light should make you stop and think, why is the patient taking this drug? Is it truly needed? Are there safer and or more effective alternatives? Does my patient have particular characteristics that increase or mitigate the risk of this medication? And keeping in mind that there are situations where those medications that are found in the Beers criteria are justified and appropriate. We should actively inquire about symptoms that patients are having to determine if they're adverse drug effects and to assess whether those could be related to medications. So in older adults, anytime that they're presenting with new symptoms, especially in relation to recent medication changes and or new medication starts, it would be important to think about, could the symptoms that these patients are having be related to the medication I changed or I started, if a dose was changed or medication itself was changed. They also recommend not to automatically defer to colleagues. Just because another clinician prescribed a Beers criteria medication doesn't necessarily mean that it's safe or effective. Use the opportunity to discuss with colleagues whether that medication is right for the patient. It's also important to think about when the medications were started. A medication may have been appropriate for a patient who is 60 years old when it was started, but as that patient gets older, it may not continue to be appropriate for that patient. And then don't let the Beers criteria distract you from closely attending to other elements of prescribing that are not addressed by the criteria. So other high-risk medications. So for example, anticoagulants or hypoglycemics, medication adherence. So again, the most effective medication is the medication that the patient can and will take as well. Unnecessary medication use. So thinking about all of the medications a patient may be using, whether they are prescription medications, non-prescription medications, herbal supplementation, are those necessary? And then considering if a patient is missing something that they should be on, and even more. There are a lot of different criteria that are available, or a lot of different resources related to the Beers criteria that are available. And these are listed here. They're available at geriatricscareonline.org. And the link to the geriatrics information that's available for resources is there as well. Some of the resources that are available are free, like this slide set where anyone can access them. They're open access and you can share them and use them to teach your colleagues and peers as well, or to refer to yourself, and others do require a subscription